Good day, students. Today we shall be covering three important topics, namely fibrocystic disease, fibroadenoma, and Phyllodes tumor. The first topic shall be the fibrocystic disease of breast. It has been asked as a short note, an MCQ, a short essay in pathology as well as in surgery. It covers a spectrum of lesions which shall be dealt with under these subheadings. On the left is a normal breast tissue with the glands and the ducts, whereas on the right I find multiple cystically dilated spaces and a few smaller cyst-like spaces. They are supported by a fibrous stroma, hence the term fibrocystic disease of breast. It usually has a spectrum of features. It is more common in individuals more than 30 years of age, and it forms nearly 50% of the breast surgical cases. It peaks before menopause and it forms the other end of the spectrum opposite to fibroadenoma. So at one end we have got fibroadenoma and at another we have got fibrocystic disease. And it can also be associated with functioning ovarian tumors because the basic cause is supposed to be a hormonal imbalance and increase in estrogen. What are the types of fibrocystic disease? As per the definition, it is a miscellaneous spectrum of changes in the breast. These can be without hyperplasia. So there is a cyst formation and fibrosis. There might even be apocrine metaplasia, but no hyperplasia. And the next group will be with hyperplasia. Hyperplasia means increase in the proliferation of cells. So there can be a simple epithelial hyperplasia, or sometimes it can progress on to atypia. Atypia is almost a pre-malignant condition. This is a simple fibrocystic change. A fibrocystic lesion can be multifocal or unifocal. It can be bilateral usually. Generally, it is widespread, and that can be an indication that it is not a tumor. In this picture, we are seeing a single lesion which can be large, maybe up to 5 centimeters. And the lesions are discrete and nodular. They are firm and shorty. Shorty means like lead beads in consistency. And they measure 1 to 5 centimeters in diameter. Usually they get accumulated a serous fluid or a serosanguinous blood mixed fluid, and they are translucent. They allow light to pass through. On microscopy, there is a single layer lining the cyst wall. So in this picture, it is a histology of a fibrocystic disease. I find that there are multiple lesions. So there is a large cystic dilatation of the ductal space, and it is lined by one or more layers of the epithelium. In this cyst, there is a pinkish tinge given to the lining epithelium, and this is called an apocrine change. The ductular cells resemble the sweat glands. There is no capsule. I am able to see a fatty tissue over here, but there is no capsule delimiting the lesion. And there are multiple small cystic lesions as well. So they are formed from the terminal ductules or the glands. And finally, they are all supported by a fibrous stroma. So it is called fibrocystic disease of breast, and it is a spectrum of change. This is the classical apocrine change I mentioned in the last slide. Look at the classical pinkish color. The cells are all tall, columnar, abundant, eosinophilic cytoplasm, and that is called an apocrine change. The classical example being the sweat gland. So cystic glands are varying sizes, apocrine cells, and they are supported by a fibrous stroma. What is the significance of the hyperplasia? This is a normal duct or a ductule lined by a single layer of epithelium. So it is normal. In some cases, there is a proliferation. Look at this picture. There is a mild increase in the number of cells lining. And this is called a simple hyperplasia. In some conditions, you find that there is a variation in the cell size, nuclear size, and there is hyperchromaticity. This we call as atypical hyperplasia. The classical feature is the line that is surrounding, that is called the basement membrane, it is intact. So this is called atypical hyperplasia. This continues to proliferate and it can fill the entire ductal space and it is called ductal carcinoma in situ. In situ means in position. And look at the cells, they are large and the nucleus is large, hyperchromatic, but no invasion. Finally, there is a breach in the basement membrane and there is an invasion of the cells into the surrounding stroma. It forms the invasive cancer. So look at the spectrum of changes. You people should mention this. Normal, hyperplasia, atypical hyperplasia, ductal carcinoma in situ, and invasive cancer. This is one condition of a hyperplasia. Sometimes you find that the cells not only project to some extent, but then they can get cross-linked. And I find multiple empty spaces. This is called a cribriform or a sieve-like pattern. And these are all benign epithelial cells which are filling the duct space. Whereas in certain other conditions, still the basement membrane is intact. But look at the variation. The nuclei are all large and they are all more haphazardly arranged. And this is a kind of a malignant transformation. Initially, it is in situ. Later on, it can go to invasive carcinoma. Hyperplasia, atypia, carcinoma. Again, a beautiful picture from the Mayo Foundation. And this is a normal breast with the glands, ductules, and the ducts. But here I am finding multiple cystically dilated spaces. A diagrammatic representation of the fibrocystic disease. The significance here is when the surgeon palpates, there can be multiple nodules. So it can be mistaken for a malignancy. That is on one side. And the real fact is they by themselves can predispose to malignancy. Either way, it is significant. One, it is a mimic. Two, it can predispose. Courtesy KO, and I find a slice of a breast tissue that is having cystic spaces of varying diameter, and the inner surface is smooth and shiny. And there is a intervening normal breast parenchyma. Again, another picture, I'm finding multiple cystic spaces of varying sizes, and it can even be bilateral. This can be diagnosed by means of clinical methods, ultrasound, mammogram, a very important parameter in diagnosis, FNAC, fine needle aspiration cytology, and the most important yardstick, histopathology. What the surgeon has to do is he has to observe and then follow up the case. Finally, if it is too large and suspicious, a surgery has to be done. This is a superb picture diagrammatically representing the fibrocystic disease. Let us trace it. These are the ductules breaking up into branches, and then towards the end I am having the acini. These ductules are lined by more than one layer of cells. which we call as hyperplasia. And then some of them can get distended into large cystic spaces. We call it a gross cyst. Sometimes they are small or even microscopic. We call them as microcysts. Multiple microcysts are there. And look at the picture over here. I am finding strands of fibrous tissue that are encompassing this. So it is a fibrocystic disease. Lot of proliferation of the glands is called as adenosis. So the various changes are that you can patiently redraw this diagram. It will definitely pay us dividend. With this, we shall go on to the next topic. Fibroadenoma. On the contrary, it is a simple topic and the diagnosis is straightforward, surgery is simple, and prognosis excellent. It is a benign tumor of the breast having an admixture of the glandular and stromal elements. That is why it is called fibroadenoma. Glandular and stromal elements. It is biphasic because both are there. And clinically, it occurs in the age of 18 to 30 years. It is idiopathic, incidentally noticed, and it is felt as a painless, mobile mass which slips under the palpating fingers. And when the clinician palpates, it is better palpated with the flat of the hand rather than the tips of the fingers. And because of the behavior, it is described as a breast mouse because it moves around here and there when you are palpating. The gross picture. It is usually a solitary lesion. Sometimes it can be dual. Firm, rubbery in consistency. A very important feature. Well circumscribed, lobulated, and it has got a condensed pseudocapsule. As the lesion keeps on enlarging, the surrounding connective tissue becomes condensed. It is called a pseudocapsule. Smooth external surface, and it is pearly white to gray white. The size varies from 1 centimeter to 5 centimeters. The cut surface is usually solid. It has got multiple slit-like spaces or small cystic spaces. This is classically described as a cut cabbage appearance. There are no areas of hemorrhage or necrosis. Look at this one. This is a gross picture that I had been describing until now. The cut surface is solid, uniform, and I am finding multiple slit-like spaces. And this is described as a cut cabbage appearance. Microscopically, all the dark lines or hematoxylic lines indicate the ductules and the glands which are getting compressed. And this pale area is the fibrous tissue. So since it is totally compressed, we used to call it an intracanalicular pattern. I'll tell you what it is. So this is another lesion wherein I am finding multiple slit-like and mildly cystic spaces, a classical cut cabbage appearance. Homogeneous, pinkish white, and it is encompassed by means of a pseudocapsule. There are two patterns basically. One is pericanalicular and the other is intracanalicular. So look at this diagram. As I told you earlier, all the dark lines indicate the nuclei, the lining epithelium of the ductules and the glands. And I find that there are some cystic spaces. Look at the letter P, it has got a lumen. And here there is a lumen. This is called a pericanalicular pattern. In some areas, it will not be there. We call it as intracanalicular. It can be kept as a slide for you. It is a specimen for you. It is a short note in the exam. Viva voce, it is a specimen. Surgery, it is a short case. And it is an MCQ. What more do you want? And here again, they are all compressed to slit-like spaces. And this is the surrounding stroma. And slit-like spaces resemble the letter I. I has got no lumen. That means it is intracanalicular. So it is A moderately cellular tumor, proliferation of epithelial and stromal elements. The tumor is composed of glandular and ductal elements from the peripheral ductular units. And there are two patterns as we had described, the intracanalicular and the pericanalicular. In intracanalicular, the stromal proliferation is in excess. It compresses the glandular lumen. In pericanalicular, the stromal components are arranged around the glandular elements. The lumen is patent. That is why it is called pericanalicular. Lumen is seen here. No areas of hemorrhage, necrosis, no mitosis. And this particular diagram, you people can draw in your records. So multiple spaces are there surrounding by the fibrostroma, and this is the classical pseudocapsule that we mentioned. And this is the fatty tissue that we see in the normal breast. The arrow is pointing to the compressed pseudocapsule. What does this picture denote? Draw this. Cytologically, sometimes cytology is given, otherwise you people can score a mark. When we make a smear, we find that the cells are all in this particular pattern. We call it as a stag horn pattern. Stag is a male deer that has got horns which are branching, and this exactly mimics it, and so it is called a stag horn pattern. So there will be epithelial cells as well as stromal cells. Both are there. The differential diagnosis can be a Phyllodes tumor, which we shall be seeing, or a tubular adenoma. And the methods of diagnosis are given here. We will do an FNAC, straightforward diagnosis, and after they enucleate, we will do a histopathology confirming the diagnosis. And the treatment is surgical removal or lumpectomy, or the better word will be enucleation. You can scoop out the entire lesion. I know this session is slightly long, but we are covering 3 questions with a number of university questions, as we shall be seeing in the last one, the Phyllodes tumor. And these are the pattern of questions in surgery and pathology. The Greek word phyllon means leaf. It is leaf-like, and it earlier used to be called a cystosarcoma phyllodes, but then sarcoma means malignant. There can be a benign behavior, hence it is nowadays recommended to be called Phyllodes tumor. The age is 40 to 50 years. It is a large bossellated tumor. Bossellated means it keeps bulging. I used to recollect the rocks that we see in Mahabalipuram, measuring several centimeters. The overlying skin is stretched, it can be ulcerated. And these are the 3 basic types: benign, borderline, malignant. Look at this one. The tumor is extremely large, not just 5 centimeters, it can be 10 or even 15 centimeters. And there will be spaces, they are not slit like, but it has got a holy leaf like pattern. And the tumor is somewhat grayish brown or yellowish brown. So here there is a lumen with the epithelium, and it is being lined by the epithelium. And the stroma, compared to the fibroadenoma, it is highly cellular, and there can be mitotic figures. So this is a picture of it, a massive tumor, bossellated appearance. Bossellated means rock-like, not in consistency but in shape. Increased stromal cellularity, mitosis, there will be a rapid increase in size, and it can lead to malignancy. It is associated with malignancy. Again, it resembles a holy leaf. That is why it is called as. Phyllodes means leaf-like. Large branching glandular spaces, sometimes mitotic figures can be present. Gracias.